It seems to be trickling, so I think we can get going. Welcome everyone to the Research Ethics and Policy series. My name is Holly Fernandez Lynch. I'm an assistant professor of medical ethics in the Department of Medical Ethics and Health Policy, and I co-chair the REP series with Steve Jaffe. Today, we're really excited to welcome Dr. Justin Klapp, who will be presenting his research on community consultation in the context of exception from informed consent in emergency research, which I'm sure he'll tell you is easier described as the shorthand Efik. And I will go ahead and introduce Justin in just a moment, but I'll make a few kind of traditional announcements for those of you who are REPS regulars. As a reminder, the series continues to be recorded unless we state otherwise, and Mary posts the videos to the Medical Ethics and Health Policy website as they become ready. This is the first session of the new year. We had really hoped to be back in person by now, but here we are. Obviously, our plans have been foiled again. We have a couple more local Penn speakers who are on the calendar over the next few months. We're hoping to have a hybrid option available starting in March, but obviously we will be in touch about all of that. And we'll be thinking about the schedule for 2023 before too long. So don't forget to let us know if there are speakers or topics that you would like to hear about in this series, especially people from diverse backgrounds or who would contribute diverse perspectives to issues relevant to research ethics and policy. And you can share those recommendations with me or with Mary. Just a quick reminder about some online ethics resources from our department. This is a series of short research ethics courses that are available for free continuing education credit. Some can be used to satisfy the research ethics training requirements at Penn and CHOP, and also flagging a new addition to this list, which is the course on ethical issues arising in global research. And Mary will put information in the chat about that. As always, we're grateful to our co-sponsors who are shown here, and to Mary Pham for ably getting the logistics of this series always working so smoothly. And now to introduce today's speaker. Dr. Justin Klapp is an assistant professor of anesthesiology and critical care, as well as medical ethics and health policy here at Penn, where he's also associated faculty in anthropology. He is a linguistic and medical anthropologist who uses qualitative methods and anthropological theory to examine issues in empirical bioethics, healthcare communication, and medical decision-making. And he also maintains lines of research in medical education and medical research ethics. So Justin, we're really happy to have you today. For all of you who have joined us, we're going to hold questions until the end. We'll make sure that we save enough time for that discussion. And if you'd like to kind of reserve your spot in the queue, you're welcome to post a question in the chat or just flag for me that you'd like to be added to the list. Okay, Justin, the floor is yours.
Right, let me pull up my slides. Thanks, Holly. All right, so I'm going to be talking about exception from informed consent regulation today, which is colloquially called Efik. And before we get started, I want to really provide some, before we kind of get into the meat of the topic, I want to provide some background to get everyone on the same page here. So there are situations in emergency medical clinical research where prospective informed consent is very difficult to pull off for three different reasons. One is the patients who are eligible for a study are incapacitated. The second is the window of therapeutic opportunity for whatever intervention is being tested is often quite short. And the third is legally authorized representatives who could provide surrogate consent are unavailable. So you can have this set of conditions where prospective informed consent really isn't possible, though we'll talk about what that means in a second. And yet it's still very important, many would argue, to do this type of work. And so in response to this, the Efik regulatory pathway was established by the FDA in 1996. And the Efik regulatory pathway is available to studies that fulfill the following three criteria. And in fulfilling them, they can then do their trials or their studies without prospective informed consent. So the criteria are that the condition of interest that they're investigating is quote unquote life-threatening, that available therapies for that condition are quote unquote unproven or unsatisfactory, and that the research cannot be quote practicably carried out without the waiver. I'm not going to get into this a lot in this talk, but you will note that all three of these criteria are actually pretty ambiguous. So various commentators have argued, for example, well, what if I'm investigating a condition that can lead to disability that down the line is life-threatening? Is that a life-threatening condition? Practicability is perhaps the most ambiguous of the three. Oftentimes these situations, it is possible to locate legally authorized representatives beforehand, but just not very often. So then practicability kind of depends on how long a research team is willing to allow a study to go for to recruit enough people, or do they have the resources to actually do that? So practicability is sort of in the eye of the beholder. So all three of these are fairly nebulous, which is relevant, but which I'm not going to get into too much in this talk. Only about 40 Efik studies have happened since the passage of this regulation. Another issue that's interesting and relevant, but I'm not going to get into too much, is that some have argued that this set of regulations is so burdensome that it's basically inhibited this type of emergency medical research, which the studies that I'm going to talk about today aren't really positioned to evaluate, but it's a relevant point. What I really want to focus most of this talk on is the requirement of community consultation. So in order to waive prospective informed consent, Efik investigators have to fulfill a whole bunch of pre-study and post-study requirements. And I would say the most burdensome one is community consultation, which is a pre-study requirement in order to get approval from the IRB. And the FDA defines community consultation as consultation with representatives of the communities in which the clinical investigation will be conducted and from which the subjects will be drawn. So you'll note that that's pretty broad, which is a theme that will continue throughout this talk. Efik can kind of be seen as an early example of the broader paradigm of patient and public involvement, or PPI, which has really taken hold over the last few decades in this country as well as in Europe. Particularly prominent in the UK. So this is a definition of PPI from the NIHR over in the UK. Patient and public involvement means actively working in partnership with patients and members of the public to plan, manage, design, and carry out research. You will notice that that also is very, very broad. Efik regulation itself, when it comes to stipulating what should be done to carry out community consultation, is highly unspecific. There was subsequent FDA guidance, but that also leaves much to local interpretation. Because of the breadth and because of a number of other issues that I'm going to sort of cover in this talk of this regulatory pathway, as soon as this was passed and researchers started doing this type of study, commentary started coming out about the confusion and the uncertainty that they were experiencing in carrying out community consultation. And these commentators asked a number of fundamental questions. For one, what's the overarching goal of community consultation? What's a community? Which communities are relevant? How do we know we're adequately representing these communities? How should the feedback obtained through community consultation actually be used by investigators in the IRBs? And so there has been an appeal based on all of this body of commentary for rigorous scientific inquiry into community consultation. And I think that's sort of what we're trying to do here in this series of projects that I'm going to report, is to get at what is really producing this confusion and uncertainty, and how can we kind of best mitigate it and move forward. So the discussion that I'm going to move through here, and I'm going to sort of combine empirical findings with discussion rather than separate them out. But it's based on two sources of data. One is an interview study that we're writing up right now, where we actually talked with Efik researchers all over the country. And I'm not going to belabor the methods of the study because I really want to get into the content, but we talked to 27 scientific personnel who had worked on Efik studies that included 18 PIs and 9 research coordinators that worked at 12 different institutions, and they studied diverse diseases and conditions in these Efik trials. The other data source that I want to talk about is sort of autoethnographic at this point, and that is that I've had the opportunity through an incredibly kind of bizarre confluence of events to participate in a community consultation for a study at Penn. So I have a colleague who's junior faculty in my department, Asad Usman, who's launching the RETICA trial, the Rescue Transesophageal Echocardiography for in-hospital cardiac arrest trial, which is basically designed to test the usage of this TEE technology in resuscitation protocols for those who experience cardiac arrest who are in hospital. And through a somewhat crazy set of coincidences, so pictured here is Samantha Stein, who's an anthropology PhD advisee of mine, this is a picture of her out recruiting participants for community consultation, desperately trying to keep her sign-up sheets dry here. Samantha really was the one who brought Efik to my attention and has been doing this work as a focus of her dissertation. And right around when she started focusing on it, she started observing IRB discussions at Penn. She came back to me one day and said, hey, there's a faculty in your department and one of his study just got designated as Efik. And she said, oh, it's Assad. And I said, oh, his office is next door to mine. So I popped over to his office, said, oh, I hear you're doing an Efik study. And so we started having a conversation. And so it was this incredible coincidence that led this bright PhD student to now work as really pushing forward the community consultation of Assad's trial with my help as well. And I want to say that Samantha has really been the driving force a lot of this Efik work, and it could just as easily be her giving this talk. So what have we done as part of this community consultation? We've done quite a number of interviews with patients, with family, with clinicians, and with hospital staff. And we're currently in the process of doing focus groups with registered community organizations and businesses like hair salons, as well as community institutions like churches. Also, we've had quite copious interactions with the IRB and the FDA, which I'm going to use to reflect on this stuff. So I want to talk about three topics. One is the issue of what does Efik actually designate, and is it sort of successful in doing so? And this gets at the really blurry line between research and practice in emergency medicine. I will say that David Ash gave quite an eloquent talk a couple months ago in this series about similar issues, so I'm not going to spend a ton of time on it on this portion, but I will say it's interesting to see how these issues play out in the setting of Efik. The real meat of what I want to get into is confusion over the community consultation process and what is really being done and what is being achieved in the community consultation process. And then I want to get into an examination of how the feedback is actually used. In some, I would say it has pretty minimal impact. And I would also say, interestingly, that most involved in the process anticipate that it's going to have pretty minimal impact. So what's going on there and what are the ramifications of that? And then at the very end, I just want to spend a few minutes attempting to explain, using some anthropological theory, what's going on here and what's producing this situation, and also sort of contextualizing this situation in the sort of broader trends within academic medicine. So I want to talk about how basically we have a combination of bureaucratic techniques, ineffable or indeterminate concepts, which create a situation where things get sort of rapidly proceduralized, and then the result is absurdity. And when I'm talking about absurdity, I'm not just talking about like stupidity. I'm talking about absurdity in the sense of the sort of classic absurdists like Camus, right? Which is like when one searches for meaning and doesn't find it, and yet forges on anyway. So that's the type of absurdity that I'm talking about. So let's get into the first of this kind of trichotomy here. What does Efik designate? So when we talked to Efik researchers who are themselves clinician scientists, right, who practice in emergency medical settings, they characterized emergency medicine as wide open, untreated disease. And so they said things like, well, right now we're just making up treatments based on historical information and anecdotal practice and what we learned in school. What's actually happening in real practice isn't based most of the time off of anything already established. And so they saw their practice as being experimental, not just their research as being experimental. So, quote, in the absence of any data or studies, patients are being experimented on. We're just not calling it an experiment. When you don't have evidence, you're basically just doing it essentially through guesswork. So ultimately, most of the people that we've interviewed, most of the Efik researchers, the Efik clinician scientists, saw little difference between the kind of risks that were in the kind and the severity of risks incurred in their practice and those incurred by their research. And so they viewed, in light of the fact that they thought there was fairly little incremental risk posed by their research, they viewed Efik requirements, particularly community consultation, as disproportionately burdensome. And I do want to pause for a moment and reflect on how burdensome they are. We've been doing this for a couple years now, and that's even in a situation where we have Samantha, who is kind of an Efik guru, just on the chance that she happened to be doing this for her dissertation. And particularly for a junior faculty like Assad, right, to launch a trial, right, that's not already based on a sort of pre-existing funding stream is really, really difficult. And especially, and I'm going to touch on this later, in the sort of academic labor environment in which many of us work, right, where things are dictated by very tight funding timelines, the pressure to get out an enormous amount of publications, and then to do this community consultation process on top of that, right, is pretty extreme in some ways. So despite the fact that they thought community consultation was disproportionately burdensome, despite the fact that they couldn't really identify a clear ethical mandate for Efik, the interviewees that we talked to had pursued Efik studies because of just sort of a general desire to differentiate their work from a history of biomedical abuses, at least in part. So they'd say things like, there's a mistrust in certain populations around what the biomedical research enterprise does, taking advantage of patients. There have been a lot of research injustices in our country, in our history in this country. It's very natural, I think, for us to be concerned about that. So what they would ultimately face in practical terms in wanting to pursue these studies is a sort of choice between, okay, well, I want to get this new approach out into practice, right? I'm going to kind of do that regardless. Should I get a QI designation or should I get an Efik designation? Ostensibly, basically, to launch the same new approach, right? But two paths that offer drastically different levels of regulatory oversight, right? So this is the kind of dilemma. And so a question is, given their skepticism about Efik, given the intense burdensomeness of community consultation, as well as all the other pre-study and post-study requirements, why do some researchers still go the Efik route and not just get a QI designation? Well, one is professional interests. I think a general tendency to not want to get in trouble, a sort of vague inclination in that direction. A research designation also incurs a little more prestige. It opens up different funding opportunities and so on and so forth. But I think an overlooked reason, one that kind of came through in our interviews, is, and I want to comment real quick on the professional interest kind of driving the level of regulatory oversight. I think that's a strikingly odd situation. I think a lot of people would agree that one of the main purposes of an IRB is to kind of protect subjects through mitigating researcher professional interests and their influence on how the ethical components of a study are being pursued. But this situation seems to position professional interests as central to how much regulatory oversight ends up being applied to the implementation of a new clinical approach, which is an odd situation to reflect on. But the other thing that I think is making Efik sort of appealing for some people is adherence to what Chuck Boss called a Whiggish history of American bioethics, right? Which is this sort of simplistic narrative, historical narrative of, the sort of the spread of bioethics in America, its sort of spread of its institutional apparatuses like the IRB is just a direct response to past research abuses and has largely, in sort of simple and straightforward fashion, been responsible for lessening those abuses, right? And I think if you adhere to that kind of narrative, I think Efik becomes, at least for our interviewees, this sort of just general index of biomedical research reform. And so to conclude this kind of first section, I think the question that it raises is, does the Efik designation actually have a clear referent? That is to say, right, does it actually pick out some worldly set of practices that are discrete and present distinct ethical challenges, right? And it seems to struggle to do so. Next issue I want to talk about is to get into the community consultation process and some of the confusions around that. So when we interviewed investigators, and indeed, as we've been pursuing this process ourselves, the two main sort of heuristics for conceiving of what collectives one is actually representing in the community consultation process are, on the one hand, disease or condition community, and on the other hand, geographic community. These are the two kind of central concepts guiding the community consultation process. And so researchers that we talk to, they define the kind of disease and condition community as, these are people who have some sort of personal experience or personal stakes in this particular issue that's being investigated, right? So either they had the condition themselves, they're at risk for the condition, and therefore at risk for enrollment in an Efik trial. They're a caregiver or a surrogate of someone who's had the condition or is at risk for the condition. And the people we interviewed had a fairly clear idea of what they thought the function of this disease or condition community concept was. And that the idea was, in getting at the disease or condition community, you could predict attitudes towards enrollment in your Efik trial, right? In other words, you could help ensure that people who ultimately do get enrolled, even though they're not consenting, are not super upset about getting enrolled. And so interestingly, the use of the disease or condition community concept is as almost a sort of proxy for informed consent. It's a transposition of prospective individual informed consent into a sort of collective space. The geographic community concept was far less clear for our interviewees. The geographic community concept is basically, you want to solicit the concerns of people who are in proximity or sort of in the catchment areas of a trial site, an Efik trial site. And a number of sort of different existing entities are used to orient geographic community consultation. So it might be neighborhood organizations, churches, businesses. Teams have done random digit dialing using zip codes. And what's really been interesting, and I'll touch on this again in the next slide, is that the different kind of extant entities that are used to orient the geographic community are often, we have found, racially marked. That is, they're sort of emblematic of the social life of particular racial minority collectives. So when we talk to, but this is often tacit. So when we talk to interviewees, they would say, oh yeah, for this study, the main kind of ways that we did geographic community consultation was we got in touch with Baptist churches and barber shops, and they would talk about all these things that were sort of emblematic of Black social life. But they wouldn't mention race as any sort of guiding focus of geographic community consultation. And we found the same thing in interacting with the IRB and the FDA, is that there's this emphasis on getting together with groups that are already, that are clearly tied in, at least stereotypically, with certain racial minorities, but that isn't mentioned as a sort of driving motivation. And I want to talk a little bit about what's going on there. But the general point about geographic community, at least for our investigators, is that they had a lot of difficulty perceiving of a function for geographic community consultation that was distinct from disease and condition community consultation. So you would see quotes like this: when you talk to people in the region, when you go to a church or a school or a board or whatever, and you ask them, I don't know what that reflects. They're not facing the situation. Unless there's really a reason to believe that people in Philadelphia should have a different view about participation than people in Birmingham, Alabama, or Los Angeles or whatever. And I don't know why that should be the case. So the question is, again, given the skepticism about the utility of this concept, why is it enduring? Why does it seem to have some appeal for certain actors involved in this process? Well, whether it's certain investigators or whether it's IRBs or regulators. For one, it seems to be operating through this sort of conflation of place and race. And as I said, it seems to be working as this sort of euphemistic stand-in for minority racial collectives. Depending on what the study site is, those racial collectives could be Black, could be Southeast Asian. We talked to a number of people where it was different collectives, but this sort of euphemistic stand-in, what's going on there? Potentially, it's some sort of vague attempt to sort of repair prior exploitative relationships between biomedicine and certain racial minorities. In my darker moments, even though I put good intentions in the talk title, I do have to admit to thinking that there's some ass covering going on in this regard, right? In the sense that if there was to be a scandal about this type of research, the worst scandal would be that a racial minority that had been subjected to exploitative biomedical practices in the past was involved in research where there wasn't prospective informed consent happening. Another potential reason that people could be moving forward with this geographic community concept, whether it's IRBs or investigators or regulators or whatever, is that they see it as doing something, they successfully do kind of see it as doing something distinct from disease or condition community consultation. And I will note that we didn't really see anyone articulate this in our interviews or have heard anyone articulate this in our interactions with IRBs and the FDA, but it would be possible to posit that it is doing something different. And Matt McCoy has written a really nice article about patient and public involvement in general, but he touches on Efik as this sort of gray area with this idea of geographic community and disease or condition community. And one could posit, right, that geographic community is doing something different, that perhaps the disease or condition community is talking to people with a sort of vested interest in the particular condition or the study, and they're concerned about their own well-being. And so what the geographic community possibly does is get a more disinterested assessment of the overall public good presented by a study. That still leaves me with a number of questions, I must say. One is, why is it geographically focused if we're talking about a study's general public good, right? You could say, okay, it's geographically focused because we want to talk to the people who might get enrolled in the trial. Well, that to me makes it then overlap with the disease or condition community, right? If you're talking to people who are at risk, they're not disinterested. Another question, and this gets at much broader debates that are well beyond the scope of this talk about sort of deliberative democracy and political theory, is this the right situation or encounter to have a broad discussion of the public good presented by a piece of biomedical research? Are Efik trialists, who are clinical trialists, best positioned to facilitate this type of discussion, and our participants even positioned to talk about this in, frankly, what are often pretty hastily scheduled, one-off focus group type things? Another question is that when a study sort of has the weight of biomedicine behind it, in other words, when there's already motivation in a particular clinical community to test a particular thing, when there might already have been certain types of funding secured, when there are already well-entrenched ideas about what type of study is necessary to adequately test a certain intervention and so on and so forth, it would seem to me like the ability to have some sort of open-ended discussion about whether this research is in the public good is already pretty tightly circumscribed, right? And so I think these are all issues that, to me, make the geographic community concept still very unclear. Another issue when it comes to confusion around how to do community consultation is methodological. These are basically, the FDA is sort of prescribing social scientific study of certain collectives in order to solicit their concerns and figure out what to do with them, which sort of invokes the question, well, how does one represent a community, right? One is, what kind of event or interaction or encounter do researchers have with these publics? And interestingly, what we found when talking to Efik researchers is that they've come to use what they call menus, which have been created by prominent Efik researchers to kind of lay out a protocol for what an acceptable community consultation looks like. So one of our interviewees said, for example, there's list A and list B. They're talking about one of these menus. And you have to choose at least 2 from list A and 1 or 2 from list B. Another issue is, how much feedback do you need? And similarly, we heard interviewees articulate that they're judging this based on precedent. And so we'd get quotes like, I think you have to reach a certain population number. I think if you say, yeah, I did 6 to 8 events, but I only have 50 people that I spoke to, then that's too little. Every IRB has a different criteria for what is adequate for a study, but I want to say more than 100 people surveyed in total. Interestingly, a lot of these interviewees would simultaneously invoke the concept of saturation, which a lot of you may be familiar with, right? Which is this idea in qualitative methods that on a study-by-study basis, one is initiating data analysis at the same time that one's collecting data, and one is thus positioned to say, okay, we now have accrued adequate data to answer our research question. Of course, that sort of classic process of saturation is directly opposed to the use of fairly arbitrary numeric thresholds based on precedent, right? So it's interesting that it's even kind of being brought up. All right. And the last area that I want to study, that I want to talk about that we've been studying is what the actual impact of community consultation feedback ends up being and why we think it kind of ends up taking the form that it takes. To put it bluntly, it seems like community consultation feedback in this Efik process is being used in very limited fashion. The interviewees that we talked to stated almost universally that IRBs rarely ask for modifications or really push for modifications to study design based on feedback. I will note that our interviews were not designed. We would have designed a totally different study, right, to assess the frequency with which people are modifying Efik trials across the whole country, right? But I will say that we heard of one instance from an Efik researcher that we talked to of a feedback causing a modification, a single instance. And that instance was that at one of their sites for a trial that they were getting together, there was a well-recognized, well-institutionalized religious collective that had big problems with the study, and the investigators decided we won't do it at that site. So I would suggest that that's an atypical situation for two reasons. One, what they did was basically categorical, right? It wasn't like, oh, we'll modify the study design to see how we can deal with these concerns. It was like, we're not going to do that site, right? The second is, it was a well-institutionalized, as I said, pre-established, pre-recognized collective that was voicing these concerns, right? So the investigator could say, oh, that's the so-and-so's, you know, I'm linking it to a sort of powerful group already. I can say, okay, we don't want to go through with this, right? I would suggest that most feedback, you know, it doesn't ask for sort of that kind of categorical change, and it's not proffered by collectives that are pre-recognized. In other words, in most situations, it's up to the investigator to do the analytical work necessary to say, to what extent is this concern representative of some collective? What is the nature of that collective? And so on and so forth. Well, our study wasn't really designed to assess the sort of frequency of modifications. There have been studies that are better designed to assess that, both of them done by Neil Dickert, who's done a lot of work on Efik. Did a survey study of Efik investigators, found one instance of a modification across this survey. The modification, I would say, was pretty minor. It was a modification to the consent protocol for continued participation. In other words, once someone's already enrolled, what's the protocol for consenting them to see if they want to stay in the study? Also, a recent scoping review of 84 Efik-related publications found two instances of modifications. One was a sort of modification to the opt-out mechanisms. I don't want to get too much into that, but in order to give people an opportunity, or what's supposed to be an opportunity, to not be included in a trial ahead of time. And one was a modification to the public disclosure plan, which is this the sort of messaging that goes out into the kind of catchment area to say, hey, this trial is happening. So one thing that hasn't really been looked at a lot, we can see that the feedback really isn't used very much, and it seems to be used for fairly minor issues. One issue is, what is the actual nature of the feedback that's getting obtained in these processes? And we've kind of seen a number of things, both through the interviews we did as well as our own performance of community consultation. For one, it's just difficult for respondents, for participants, community consultation to comment on study specifics. So one researcher said, you can't understand as a layperson some of the studies that we do. We have a hard enough time designing it as physicians. I'll tell you honestly, I don't really get particularly good feedback from when I do these consultations, nothing particularly useful. And then what appears to happen in a lot of these scenarios is, because of this, there ends up being a sort of ratcheting down of expectations for what community consultation is going to do, right? So the initial thought might be, oh, we're going to sort of co-design a trial with help from the lay public. But then expectations sort of rapidly get shifted down to, okay, we're going to educate the public, right? They're not going to necessarily, we're not actually expecting that much influence on the design of the study, right? So for researchers, the community consultation seems to often sort of end up almost inevitably taking on this educational bent, right? It becomes an opportunity to explain, quote, the nature of emergency medicine research and why you can't always get consent. But one thing that I haven't seen a lot of stuff about, and that it was clear from the interviewees we talked to, and also through doing these things, is that the feedback that you get from lay people about these studies is very often related to their own personal medical experiences. It's not about the particularities of your trial that you want to do, right? And so here's one quote that I think shows that from an Efik PI. I had the booth up at Starbucks. One gentleman came up to us and I said, I just want to tell you a little bit about the study that we have going on and I can get some feedback from you. And he's, well, all you doctors and nurses don't know what you're doing. I was in the ICU and they kept telling my family that I was going to die and that I was going to be brain dead. And do I look brain dead to you? It was totally unrelated to the research. He was just unhappy with his care. So what's going on here? Why is feedback being used in such an infrequent and narrow fashion? One simple reason is the sheer complexity of Efik trials. Another sort of related reason is that I think it seems to me, at least, that when regulators and IRBs think about how these trials are presented to the public, they're very concerned with being exhaustive in detail in terms of detailing all of the risks and things, right? It becomes this sort of legalistic thing. As one does, acting on precedent, we have looked at some guides from prior Efik groups for how they presented these trials in community consultation. And I will say that the health literacy level of these presentations is extremely high, in my opinion. Another perhaps more fundamental issue is that the scope of the feedback is restricted a priori, and I've kind of alluded to this in past slides, right? That there's so much going on in the sort of scientific and regulatory apparatus prior to the community consultation occurring that investigators and IRBs aren't really expecting or positioning people to modify that much about the trial, right? And so here's a very blunt appraisal of that from an interviewee. It doesn't matter. We still have permission to do the study because we know that the risk benefit is okay. That's already been approved through different grant mechanisms. And then I think most fundamentally, and in my opinion, most interestingly, this issue of the fact that community consultation participants really speak from their own interactions, whether good or bad, with medicine. That's the body of experience that they have to draw on. That's how they relate to medicine and to medical research, right? Some of these experiences are quite idiosyncratic. Some, on the other hand, are bad manifestations of broad socioeconomic and racial inequities, right? And so we have to ask the question, are these broad socioeconomic and racial inequities best addressed through putting trialists out there to talk to people and then try to manipulate the details of a specific pragmatic trial? The last kind of issue that I want to touch on before I kind of get into some of the takeaways is the issue of trust and respect. So in FDA Efik regulation, it states that not only is the point here to get feedback in order to modify studies, it's to build trust between medical researchers and communities and to show respect for lay people, right? A subset of our interviews articulated that same thing. But my question is, how does building trust or respect do anything to establish that a study is ethical? What can be framed from one perspective as trust building can just as easily, I think, be framed as PR, can just be easily be framed as salesmanship, right? And that was actually something that really was a thorn in the sides of our Efik researchers that we interviewed. They really worried when they thought about their role in this whole process that they were basically acting as salespeople for their work. So quote, most people sort of, sure, whatever, doc. The way a physician or investigative team pitches the study to the public can absolutely influence their receptivity. It's like a salesman. Some salesmen are very good at what they do, and some are not so good at what they do, even though they're selling the same product. And I have to say there's a flip side to this. It's not always trust that's resulting from these interactions, right? Some commentators have recently noted, they've coined this term instrumentalized trusting, right? In other words, a researcher goes out into the community, build some trust with some group of lay people, basically in order to facilitate the attainment of certain career objectives. When those career objectives are obtained, or when it's no longer convenient or practical to maintain this relationship with this group of lay people, it drops off, right? And we saw that actually when we've gone out and talked to people for our community consultation. Some of the groups we've talked to had pre-existing cynicism and felt they were already being tokenized coming in because they had relatively recently interacted with Penn around vaccine outreach and had felt that they had been promised certain things that hadn't been delivered. So given these findings and given what other people have found in this space, what is the apparent state of Efik 25 years after its passage? I just want to offer a quick study. One is it struggles to bound a discrete set of activities that pose distinct ethical challenges. It ends up sort of deriving a lot of its appeal, I think, from serving as a vague index of biomedical research reform. It's highly burdensome. The concepts driving the community consultation process are quite ambiguous. Nevertheless, community consultation has rapidly coalesced into rules and procedures. Researchers and administrators question quite openly, I would say, what these rules and procedures are accomplishing, but they do them anyway. The feedback obtained doesn't typically modify research plans in any substantive way, and frankly, it isn't expected to from a lot of people I've interacted with, and how the feedback should be used and what the sort of overarching goal here is remains highly under-theorized. So in the last couple of minutes here, I want to attempt using some social scientific inspiration, a sort of broad explanation of what I think could potentially have led to this situation. And I'm going to talk about how bureaucracy and ineffability contribute to proceduralization, which contributes to absurdity, which seems like a mouthful right now, but I'll get into each one of these in turn. So interestingly, right in the mid-90s, when Efik was getting passed, at the same time, anthropologists and to some extent sociologists were noticing that in higher education, there was this tremendous influx of techniques from corporate bureaucracy that really started in the 70s and 80s and has really intensified over the last few decades. And so there's been this general shift of corporate bureaucratic techniques into the arenas of government, science, and education, right? And I'll note that medical research lies at the nexus of all three of those areas. And the term that's been coined by anthropologists to describe this movement is the audit culture, right? So it's this tendency from the corporate bureaucratic world to render everything that's going on in an organization reportable, transparent, right? And the idea is that if everything's reportable and everything's transparent, your bureaucratic structure will be the ideal bureaucratic structure, and that it will be purely meritocratic, right? Is that everything is governed by sort of detached rules, right, and procedures. And so as this audit culture has developed in government, science, and education, we see this proliferation of bureaucratic instruments, which I think a lot of us are very familiar with as modern academics: performance reviews, progress reports, metrics, surveys, certifications, accreditations, funding applications, and so on and so forth. At the same time as these bureaucratic techniques move into these areas like universities and medical research, right, what also moves in is what I would sort of call the visionary language of the C-suite. We see all these concepts that are with extremely ineffable content, right? Definitional content: leadership, quality, stakeholder, innovation, excellence, strategic planning, best practices, evidence-based, patient-centered, and in the area that I'm kind of talking about, patient and public involvement, community engagement, community consultation. And so what I mean by ineffable, right, is simply, right, that what is the dictionary definition of these terms, right? What is their sort of semantic content? I don't know that some of them really have much, or that people would really be able to agree on them, right? And so what happens with this type of terms is they become what in linguistic anthropology parlance, Bonnie Urquioli, linguistic anthropologist, has called strategically deployable shifters. In other words, they don't have much definitional content, but if they're used enough in particular contexts, they sort of pick up certain associations, but those associations don't necessarily have to do with the sort of concepts themselves and what they're trying to denote. They can just as much have to do with like qualities of the person saying them. Like, oh, if I say the right lingo, people will know I'm in the know on this topic, and I will be sort of able to navigate this bureaucratic space. So what happens when you get this combination of bureaucratic techniques and ineffable concepts? What you get is the rules and the procedures, right? The bureaucratic techniques start to stand in for the concepts, right? How do you make an ineffable concept concrete? You basically operationalize it using some rule or procedure, right? But what happens there is that the means, right, that we're supposed to achieve some goal, right, actually become the ends in and of themselves, right? There's, in other words, a sort of distortion that happens. Actors in particular spheres of activity start to do the rules and procedures for the sake of doing the rules and the procedures, right? And I will note, and I won't dwell too much or get too preachy on this, but this is happening. I notice it in every area that I do research, right? So Holly and I have done work on IRB quality. Seems like it's happening in that area, right? In terms of are IRBs really focused on the goal of participant protection, or are they measuring things related to efficiency? It's happening in clinical ethics. There's this idea of shared decision-making, for example, which I would argue is highly nebulous to the borderline ineffable. In order to kind of remedy its ineffability, what happens? Well, shared decision-making gets equated with decision aids, right? And the whole quest becomes, can we implement decision aids? Medical education, we get these ineffable concepts like leadership and teamwork and professionalism that we want to see in medical students and residents. These concepts are pretty ineffable. Rather than discuss what we're actually kind of looking to see, we see the development of the competencies movement, and we get this enormous number of checklists and guidelines and criteria that get operationalized to stand in for these ineffable concepts. And the end result is absurdity, right? Because eventually it becomes apparent that these rules and procedures are empty, but we all still do them, right? And so what the anthropologist David Graeber has argued, and he wrote this book called Utopia of Rules, which I think was a really nice look at the dominance of bureaucracy in contemporary society, is that this is ultimately kind of the result of powerful institutions of government, education, and science sort of superficially addressing inequities. If you do that through a combination of bureaucratic techniques and ineffable concepts, absurdity is the end result, basically. I don't want to take up too much more time, but I do want to touch on what can be done moving forward to not present a totally bleak picture here. There are two broad things that need to happen. One is that we need to combat this ineffability, right? We need to think more. We need to think longer and harder about what Efik and what PPI more generally is actually attempting to accomplish. And I'm not just talking about sort of philosophizing about the ethical goals of PPI and Efik. That's very valuable. I'm really talking also about empirical work, right? Like, we need to get down in the trenches and figure out, okay, if we're talking about communities, what collectives are actually out there? On what basis are we kind of calling something some sort of collective? What relations in here sort of within and across these collectives? How do concerns about medical research map onto these collectives? How is power already distributed within and across them? What kind of influence on medical research are they even positioned to have? And what type of methods can we develop to actually do justice to this complexity? And the other thing, which is, I think, perhaps even more important at this point, is changing the bureaucratic environment, right? Really thinking about which bureaucratic features of these really complex organizations in which we work inhibit nuanced interaction with lay publics. I already mentioned the academic labor environment, right? I would posit that if universities, for example, which really love community engaged research, if they want really serious and rigorous community engagement to happen, changes would have to occur in the academic labor environment so that researchers actually had the time and the space to do this. The other thing is we all kind of need to address our complicity in these processes. I think we do the rules and procedures because that's what advances our careers, right? But at some point, some turning point needs to happen where it's like these rules and procedures are empty, right? And in fact, sometimes they can even be harmful. What are we going to do to change this picture? And with that, I will stop.
Okay, thanks so much, Justin. And go ahead, folks, if you want to use the raise hand function or put a question into the chat, I can read it. Otherwise, Justin, I have a million questions and comments, unsurprisingly. So let me just launch into those while we're waiting for other people to let me know they want to speak. One question related to the work that we've done together on IRB quality more broadly is this challenging metrics question. How do we know, and what would we measure to know that IRBs are doing a good job? So what would we need to measure to know that community consultation worked, right? So one thing you mentioned was, the number of studies that are altered in some way as a result of community consultation. I think that's a reasonably good proxy for, we would expect there to be some kind of delta, obtained from using this process. But I'm wondering, from your perspective, if this is something we ought to abandon or change, we would need to know whether it's working and how we can measure that going forward.
Yeah, I mean, I don't know if I think of it in terms of measurement, but I think the more, and that's what's driving this line of work, the more empirical research on this, the better, in terms of figuring out what's actually going on before we kind of decide what to do with it. I think, as I've discussed with you in relation to our IRB work, I'm somewhat terrified of implementing new measurements to solve the problem of empty measurement. So I would say that I would like to see empirical work being done that's fairly, oriented to trying to figure out what's actually going on. And then I want to see a lot of thinking about what we're actually trying to do and how feasible that actually is before even thinking about how to actually evaluate whether it's working. That's the point that I'm at in thinking about this.
Right. You have to specify the goals before you can start measuring whether they've been achieved.
Yeah.
Okay, I don't see any hands raised yet. So I'll ask you another question related to this challenge about complicity. So that's, that is a tricky thing to address, right? So we are in an institution and facing a set of regulatory obligations, right? Where we have to do, we have to follow these rules if we want to do this kind of research. So in the interim, right, I think I'm wondering what your proposal is before we can get all of that empirical work done, right? Do we just kind of keep going along and doing this kind of less than meaningful community consultation? Should we be hiring people who have greater expertise than most biomedical researchers might to do this kind of qualitative work better, or maybe, who are unaffiliated with the research, so they would be less conflicted or less salesmanship about it? Just wondering what to do in the meantime.
Yeah, I mean, I think that, more empirical work needs to be done, but I think there's enough out there to say at least that there's a problem here, or a whole set of problems here. And I do think that one way of getting that in the near term is to actually give people the space they need to do this in a rigorous way. And that would involve, like I said, sort of changes to the academic labor environment. And, right, like I think the health sciences, from my perspective, have a tendency to kind of reinvent the wheel, right? So it's, do we have the time as researchers to actually look into other fields that have been thinking about these issues for a while, ruminate on the concepts, think about and have the ability to bring people on board, right? Like Samantha say, who are really well positioned to do this type of work, and so on and so forth. So I think loosening the reins a little bit so that people could approach this in a more nuanced way in the short term seems possible to me, before getting into the area of regulations. And one thing I want to add is, like, the danger of just continuing to do it like we're already doing it is that it seems in retrospect like we've successfully done a bunch of community consultation, right? And then entities like universities can key on that and say, oh, look at all this community engaged research we're doing, right? And then that cements this kind of process in and makes it difficult to change, when a lot of people know that what's being accomplished is actually, in a lot of cases, quite minimal.
Yeah, sometimes in the law, we think about things as a legal fiction, right? Where, you just kind of use this concept and model, but everyone knows it doesn't actually work the way it's supposed to, or achieve the goals it's supposed to. I had another kind of broader question about the relationship between community consultation and IRB review of protocols in the first instance, which is, with a really critical frame, you could use the idea of community consultation as an indictment on the IRB system itself, right? That it kind of acknowledges that IRBs are not themselves representative of the communities where research is being done. If we need to go out into the community to get further perspectives. And so I'm wondering whether that resonates with you, or whether you can, create a story in which IRBs and community consultation are really supposed to be doing different work.
I think to some extent it's an indictment. I mean, I would say that people who are working in IRBs, from what I've seen, are doing their best to deal with these regulations in a way that makes sense, So I certainly wouldn't want to throw any people working on IRBs under the bus, but yeah, I do think that it's a sort of attempt to paper over the inadequacies of the research ethics review system, in the sense that this sort of like glaring sense that maybe it's not in touch with what the everyday person really is concerned about, right? But it's a papering over in the sense that it then positions researchers as having to deal with these kind of sweeping societal issues in a way that I think is just impossible.
I see a comment here in the chat from John Mertz. John, I apologize for not seeing this previously, but he notes that some researchers are using a simple waiver, a waiver of informed consent under the common rule to perform these trials, assuming they can convince the IRB that the risks are no greater than minimal. John, I don't know if you wanted to elaborate on that.
Yeah, so one of the things, so I'm actually doing I've been kind of looking into the waivers and use of Efik. And I have to first say, thanks, Justin, that was an interesting talk. One of the things I don't really kind of concern myself with is the consultation part of this. But I should say that my recent count, which finished this morning with your identification of this trial at Penn, is that there are 69 trials, at least, 6 of which have not yet enrolled. So the studies by Klein and by Feldman and others really failed to capture some of these things. So I always saw the consultation and the public notification as kind of like an effort towards transparency and openness about these trials. And I have to say that in surveying these researchers, that some of these researchers just do not respond to requests for information about their trials. For instance, there's a woman named Kidwell, who was at she's I think in UCLA, I believe. She ran an Efik trial that actually had 1 of 21 sites that had an Efik waiver, and the other sites all got consent. Right? So it's like, how did you get an Efik waiver for one site? What was different about it? And she wouldn't respond. She didn't respond to a phone call. She didn't respond to emails either. So, in some sense, I mean, it seems to me that it would be much more useful to kind of like let communities know when they've had research done on them, and make it much bigger effort about, instead of trying to solicit information like you've talked about, solicit information that would have marginal utility for the research and the design of the research, letting communities know that this is ongoing, I think would be much more useful itself. So, and I have to say that we're not being transparent with these trials, that that it's difficult to identify these trials. So the two systematic reviews that were done missed some of the trials that have been done under this mechanism. And the bigger issue is, of course, and as I alluded to in this comment, is that researchers I've heard it now from a couple of Efik researchers, is that if their trial, Efik is for trials that pose more than minimal risk. So if you're proposing a trial that poses less than minimal risk, it's off to the races. You just use you just sidestep at the use of Efik. And then it's near impossible to find these trials. And the only way to kind of like really figure this out is to do a systematic review, collect all RCTs and read the methods, right? So this week, I actually had a colleague at Pitt kind of tell me about some trials that were kind of new to me. Okay, I missed them. And he turned me on to some trials run by a guy named John Holcomb. Holcomb probably was in your sample. You may have talked to him in your interview study. But he has run a proper Efik trial. And now I have just discovered a couple of trials that he ran without using Efik. And it's all because it's minimal risk. The papers say nothing about consent. They say the papers only say that the studies were approved by the IRB. Thank you very much. Right? They say nothing about consent. And that's one of the problems from kind of a transparency perspective, is people are not being transparent. In fact, the Penn program that you just announced on its clinical trials registry does not identify that they're going to use Efik, that they're going to waive consent. In fact, most of the clinical trial registries don't even mention that. right?
John, sorry,
finally,
we're out of time, so I just want to give
Okay.
Justin the chance to say any concluding remarks before everyone logs off.
That's great to know, John, especially the point that these reviews are missing the existence of some of the trials. I will say that that's been our experience as well, is that this is immense gray zone. And when it comes to identifying these trials, and I will say, just to conclude, there's that's a central point among the people we interviewed, is they don't view their studies as often meeting the threshold where they should be designated as Efik studies, because they see things in terms of incremental risk, right? How much does it actually differ from what we're doing in practice? That's great points. We should talk further. Thanks.
Yes, we should. Thanks. Thank you.
All right. Thanks so much, Justin, for a really thought-provoking talk, and for all of our attendees. See you next month.